Hello, student doctors. Let's talk about fibrates. Here is both a structure and a label. They've been widely prescribed since the 80s, and these drugs have been found to be safe in long-term use. Peroxisome proliferator antigen receptor alpha, PPR alpha for short. It's a member of the nuclear receptor superfamily of ligand-activated transcription factors. So the target genes regulated by PPR alpha include those involved in fatty acid metabolism in tissues with high oxidative rates such as muscle, heart, and liver. We're going to focus on the liver. Turns out that fibrates activate PPAR alpha. This increases liver enzymes that increase the metabolism of triglycerides. Collectively, these target genes enhance fatty acid uptake, increase conversion of acyl-CoA derivatives, further catabolism via beta oxidation. They induce lipoprotein lipase activity and enhance the production of high-density lipoprotein. Some ligand binds to a receptor and drives that ligand receptor complex into the nucleus, where it drives expression of target genes. Amongst the more familiar ligands associated with nuclear receptors include thyroid hormone, which binds to the thyroid hormone receptor, vitamin D, which binds to the vitamin D receptor, progesterone binds the progesterone receptor, estradiol binds the estrogen receptor, and each of these receptors binds to their respective response elements in tissues where they're expressed. So liver-specific gene expression is regulated by PPAR alpha. And this was a superfamily of transcription factors, many of which you'll recognize in your studies in medical school. The glucocorticoid receptor, mineralocorticoid, progesterone receptors, androgen, estrogen receptors, thyroid hormone receptors, retinoic acid receptors, vitamin D receptors. This is a very large superfamily. We have 48 members in our body. Among them are orphan receptors. They call them orphans because they are unsure of their ligand. And then there's the so-called adopted orphan receptors, of which we're talking about PPAR alpha, which is activated by fibrates. The names of which are shown here include treatments for dyslipidemia and severe hypertriglyceridemia. Fenofibric acid and gimfibrazole, as we'll see, is a little bit special amongst the group. It's a primary prevention of coronary heart disease as well as hypertriglyceridemia. Fibrates are contraindicated in kidney disease, active liver disease, pre-existing gallbladder disease, contraindicated in nursing mothers, and as always, those with known hypertension. And gimfibrazole is a little bit special, and we're going to talk about this later in the lecture. Our abnormal liver tests, which is increased AST, ALT, CPK, as well as the occurrence of rhinitis. In general, though, fibrates are well tolerated. There are GI side effects, upset stomach, and abdominal pain. In certain studies, there was a 10% increase of GI side effects compared with placebo. With other studies, the incidence was the same. Fenofibrate manufacturers recommend baseline and periodic liver enzyme monitoring. Elevated liver enzymes were observed approximately 5 times more fenofibrate-treated patients when compared with placebo-treated patients. Enzyme levels fall when the drug is removed. Serum creatinine showed a slight increase in fibrate-treated patients. We'll link to a 2010 Accord study. If you click on this link, you can see a 2010 landmark Accord clinical trial and read all about it. Serum creatinine levels increased by 0.2 mg per deciliter in elderly patients when compared with pre-fibrate levels. The American Heart Association in 2013 recommended that serum creatinine should be checked before, 3 months, and every 6 months thereafter. As you know, serum creatinine is a measure of kidney function. If GFR is observed to be less than 30 mL per minute, fenofibrate should not be used. If it's between 30 to 59, the dose of fenofibrate should not exceed 54 mg per day. So in summary, fibrate drugs can cause a slight increase in serum creatinine levels. This is likely due to an inhibitory action of fenofibrates on OCT2, organic cation transporter. So it's a transmembrane transporter. Creatine from the blood into the kidney. Fibrates do not exacerbate end-stage kidney disease. Fibrates have been shown to significantly decrease the progression of albuminuria. In general, gimfibrazole should not be taken with a statin. Fenofibrates do not appear to increase the risk of muscle toxicity when combined with statins. Fibrate drugs can increase the concentration of cholesterol inside the gallbladder, and this may lead to gallstones. An older fibric acid called clofibrate had this effect on folks, and it was eventually pulled from the market. Other fibrates, therefore, have been closely scrutinized for their risk of creating gallstones. Cross-randomized trials retrospectively not observed any consistently greater gallstones when compared with the placebo group. It may be that those that are more likely to be prescribed fibrates are just those people that are at high risk for gallstones. When fibrates are taken together with ezetimibe, the risks may be higher. Consuming fibrates increases the risk of myopathy, the most serious form of which is rhabdomyolysis. The risk of rhabdomyolysis increased in elderly patients with diabetes, renal insufficiency, or hypothyroidism. Fenofibrate can also increase serum transaminases, so you have to monitor ALT periodically during fibrate therapy. Fenofibrate can reversibly increase serum creatinine levels. If you start suspecting gallstones, gallbladder studies are indicated. Coumarin-type anticoagulants interact with fibrates. Dose adjustments of these anticoagulants may be needed to maintain the PTT at the desired level. Should be checked before treatment, then 3 months of initiation of treatment, and every 6 months thereafter. In patients with significant liver disease, fenofibrates are contraindicated. Fibrates are contraindicated in patients with suspected gallbladder disease. There are no black box warnings associated with fibrates. When talking about fibrates, the FDA did something very unusual. They withdrew approvals that the FDA had previously given for the use of combining fibrates with niacin and statins to treat high cholesterol. And I've provided some clickable links. A New England Journal of Medicine article, niacin in patients with low HDL cholesterol levels, effects of extended release niacin with loropiprant in high risk. Here's our special friend gemfibrozol, very strong inhibitor of a particular cytochrome P450 called CYP2C8, which is important in drug metabolism. So if a compound inhibits CYP2C8, it's at increased risk for drug-drug interactions. Thus, as you would expect, there are many drug-drug interactions with fibrates. Bile acid sequestrants interact with fibrates. Colchicine interacts with fibrates. Ezetimibe interacts with fibrates. Immunosuppressants cyclosporin and tacrolimus interact with fibrates. Warfarin and fibrates interact. Because gemfibrozol is a strong CYP2C8 inhibitor, it can increase blood levels of co-administered CYP2C8 substances. Examples of those are listed here: dazubafir, enzalutamide, and glitazone. Because gemfibrozol is an OAT1B1 inhibitor, OATP1B1 and hepatic uptake transporter. Thus, gemfibrozol likely increases blood levels of other OATP1B1 substrates. Gemfibrozol may increase blood levels of co-administered OATP1B1 substrates. Gemfibrozol should not be co-administered with simvastatin. Decisions about the use of fibrates in geriatric populations should be made on the basis of renal function. During pregnancy, as you can imagine, there's no well-controlled studies in pregnant women. Fenofibrate should only be used in pregnancy if the benefit outweighs the potential risk. As fibrates appear in human breast milk, the drug should not be used by nursing mothers. Okay, student doctors, that's it for fibrates.